And Robert,
Hi, Yura. How are you?
Hello, good morning, everybody.
welcome to
morning.
Montefiore.
Thank you very much for attending the New York Coronary and Vascular Summit. This is our first edition. We have a very interesting case that we're going to be working through. I'd like first Robert, our co-director, to introduce our team, and then our fellow, Dr. Munoz, is going to give us a presentation of the case, and then we're going to talk about the approach that we're going to do in this complex case that you will see soon.
Yeah, good morning. I'm Robert, and again, thanks everybody for taking valuable time out this morning to join us. We have a great staff here. We have our two nurses, Angie and Lourdes. We have our technician here, Michael Kaur, who's been here for probably longer than I have, and just a great team. And we have our interventional fellow here. He's homegrown. He's from Montefiore Hospital. He decided to stay here another year because he loves us so much. So I think he's going to present the case now.
Good morning, everyone. So for today's conference, this is our peripheral case. This is a 63-year-old smoker male with a history of hypertension and hyperlipidemia. He also has an extensive history of peripheral artery disease. He got a stent in the left common iliac artery. That was in April 2017 when he presented with claudication. And also in September 2017, he also had a PTA with drug current balloon placed in the left SFA. As per we know, he also has the CTO of the right SFA with distal reconstitution via collaterals from the profunda. He continued to have severe lifestyle limiting claudication of the right lower extremity. Fontaine class is 2B, abnormal ABI with 0.56 in the right and 0.67 in the left. Medications, aspirin, clopidogrel, statins, and blood pressure medications, normal renal function, and our patient is here today for endovascular treatment of the right SFA.
Thank you, Dr. Munoz. So let's show you the films of the case that we are going to be doing this morning. Actually, this was not the case that we're going to present, but our patient bailed out yesterday, so we had to find another patient. So this is a little more complex than what we would have liked to, but you know, it is what it is, so we got to work on it. So this is a patient that, as you see in the films, has an occluded right superficial femoral artery. There's no ostium, and that's what makes it very complicated. It's hard to advance a wire if you don't know where the ostium comes out. You have the SFA that reconstitutes a little above the adductors canal. You see the popliteal, and then you have 3-vessel runoffs. So the plan was to get contralateral access, try to find the ostium of the right superficial femoral artery. If we couldn't, then we go retrograde transpedal. So what we did, we got contralateral access, and we also got transpedal access via the right dorsalis pedis. With the cameras, if we could show the access that we got in the foot. Okay, so Robert got access in the right dorsalis pedis, as you see here, and we have a 6 French slender sheath, and we have the usual contralateral access to the left common femoral artery, which we cross over with a 45 centimeter 6 French crossover sheath.
So Jose works very closely with the ultrasound team here, and the pedal access was obtained via ultrasound guidance. And the sheath we have is a 6 French slender sheath, in which Jose uses all the time because the outer diameter is of a 5 French, the inner diameter is 6 French, and we think that this is probably a safer sheath to use than 6 French sheath.
So Jose, you are ready for both scenarios, going antegrade or retrograde. Do you have a certain plan which one to start first, and what are your criteria of deciding which direction you start for in the beginning?
So, yeah, thanks for that question. That's actually a very important one. We usually try to do antegrade crossing, that is contralateral access up and over, and then trying to get the wire antegrade into the right superficial femoral artery. But as you see here, it's very hard to discern where is the origin of the right superficial femoral artery. The profunda is very, very clear, but the SFA is not. So I have an idea where the ostium should be, and what we did is that we put a catheter down and we probed, and you will see now that the wire was able to at least puncture the ostium of the right superficial femoral artery. Want to show the next picture, please? So here we are. We're able to get a 035 stiff, straight glide wire with the support of Aquatempo vert tip catheter, which is what you see here. And we're going to work it down. So I'm going to try to loop this wire if we can and advance it down. Most of the times the wire gets into true lumen and distal SFA. If not, we'll have to get a reentry device. If that doesn't work, then we'll be a little more creative and try to come retrograde. All right. Robbie, you want to hold the catheter there?
So
right
this
now,
is the first wire you tried? This
Yes.
is your first choice?
This is my.
Straight through.
If I have a defined ostium, I like to go with stiff angle glide, but I do not have a defined ostium, so I had a vert tip catheter, which I directed to where I thought that the ostium of the SFA was, and then I poked with a straight, stiff glide, and thankfully the wire went through. I don't know if this is going to reconstitute down into the distal SFA, but we're going to try.
So, Jose, while we watch you trying to get through with the wire, and you're too fast for us.
He's done.
Let's see. Let's not count victory yet.
But I would like to ask, while we watch you doing those first steps, asking here, we have a very great panel together, and maybe we start with Doug. So does it fit your symptomatic patient that the guidelines said class 1 indication?
Yeah, I think this does fit the guideline exactly, and I think clearly, they've evaluated the patient carefully. The patient has the symptoms. There also are the adjunctive hemodynamic data that they have suggesting that this is a flow-limiting lesion, and then it just boils down to the kind of anatomic issues and a discussion of risk-benefit with the patient here.
Sahil?
I think it's the important point also is that this would have been a task D lesion. As Doug pointed out, the old guideline statements would have suggested this is a surgical first approach. But with the techniques available, you can see he's already reconstituted into the true lumen. And he's crossed this 20 centimeter CTO in about 60 seconds. So whereas this would have once been a very difficult case, I think it's quite achievable with today's technology.
We see here the catheter following the wire that Jose is pushing forward, and he goes directly following the vessel contour.
So I think we've reconstituted. I'm not 100% sure. I'm going to put an angle wire and see if it goes into one of the tibial vessels to ensure we're in the right place. If I'm confident that we've reconstituted, I inject a tiny amount of contrast. Again, I don't like to inject contrast unless I'm almost 100% sure that I'm in the right place, because otherwise you make the dissection a lot worse.
So Jose, you're changing now to an angled wire so you can control better its direction.
Correct.
You can navigate better through the blood vessels. And you couldn't hear, but we have here a very, I think, interesting and important question from the audience. It's about embolization. Are you concerned about distal embolization while going through this, occlusion?
Yes. So we routinely use embolic protection devices in two instances: in very calcified vessels or instant restenosis. Contrary to the coronaries, where the risk of embolization is not that high, and the periphery is very high because it harbors many times a significant amount of thrombus. So, as important as it is, the embolic protection device question is then what are you going to do in terms of treating that vessel? Are you just going to balloon it? Are you going to use atherectomy? Are you going to use laser? So if I'm concerned that the patient may have an increased risk of having thrombus, then that would dissuade atherectomy, and I may perhaps use something like laser that will vaporize the clot.
And of course, doing having embolic protection, first you have to cross the lesion. So where do you think you are now, Jose, with the wire? It seems like you're moving very fast.
Well, I'm hoping I'm in the pop, but we're going to see. We're going to see if I'm in the right place or if I'm in subintimal space. If I'm subintimal space, we're in trouble, and I guess you guys could help me out. We'll find out.
Well, you made such quick work across in this lesion that it's hard to have a solid conversation here about the challenge that you faced. Say that wire hadn't crossed. Do you have in your mind kind of a wire escalation algorithm of what you would have used next and what would have made you kind of decide? I know you're kind of working and it's hard to work and talk.
Yeah, no, it's okay. So normally what we would do is continue with our 035 stiff glide wire. I may have exchange for angle glide instead of trying to cross it with a stiff straight. If that wouldn't have worked, we will get a re-entry catheter such as Outback or Pioneer, and then try to get back into the true lumen. But in that case, we have to take the 035 wire and use a 0.014-inch wire through the re-entry device. Now, many times, it's difficult even to get re-entry with these devices, and in that case, we would have used the retrograde transpedal axis that we already have and try to cross retrograde. Now, many times as well, retrograde crossing doesn't work, and you advance your wire, you think you're going to re-entry the common femoral, and you don't. So in that case, we'll consider doing a cart technique in which we will come retrograde transpedal, advance the balloon, and try to open the subintimal space, and hopefully with the antegrade wire, try to perforate or fenestrate that dissection plane and recanalize. If that doesn't work, then we would try to do a combined cart and reverse cart technique in which we would balloon both subintimal spaces, that is antegrade and retrograde, and hopefully we'll break that subintimal membrane and create a new lumen.
Jose, it's Mitch Weinberg. Now that you've chosen to use a relatively robust sheath in the pedal access at the beginning of the case, do you find that you're now obligated to leave it in for the entire procedure and remove it later? A lot of people are using lower, smaller bore catheters, especially when they're putting them in de novo at the beginning of the procedure so that they can remove them intra-procedurally. What's your thought and reasoning for using such a big sheath in that pedal from the get-go? Yeah,
so in many instances we get a transpedal access and we don't put a sheath. We do everything sheathless. In this case, because I was concerned that we may have to do a cart technique, that's why I decided to use a sheath. I don't think it's going to be a problem here. I would not take the sheath in the middle of the case because she's fully anticoagulated. What we'll do after we're done with the case, we'll pull out the sheath and we should be fine. If we were not going to be considering a cart technique, then perhaps we would have gone sheathless.
So I'd like to remind everybody too that although this is a 6 French sheath, the sheath that we used is something called a slender sheath. So the outside diameter is equivalent to a 5 French. I suppose we could have used a 4 French sheath, but this was sort of a compromise between a really 4 French sheath and a 6 French sheath.
Can you share with us what is your anticoagulation and antiplatelet status with this patient right now?
Yeah, so this patient is currently on aspirin and Plavix. He had a stent, a drug-coated balloon placed on the left superficial femoral artery not too long ago. So he's on aspirin and he's on Plavix. Right now, we're anticoagulating with bivalirudin.
Dr. Pinto, you wanted to comment?
Yeah, Jose, it's Dwayne Pinto.
Dwayne, how are you?
Wonderful technique, as Doug said. You're moving. Your hands are moving faster than my mouth, which is a rare thing. But as you alluded to, CTO techniques were actually in the periphery well before they were in the coronaries.
Correct.
But one question is, it always stresses me out as I get to the distal to the popliteal of whether I'm intraluminal or not, and then giving an injection antegrade. I wonder about giving an injection from the retrograde sheath since it reconstituted at Hunter's Canal, you would probably be able to see if a catheter or a microcatheter were placed up the pop retrogradely to see whether you're central, because the hydraulic dissection antegrade may make me worry a little bit.
Correct. That's the reason why I got down with the wire and manipulated to ensure that it was going into a tibial branch. Because as you said, sometimes we think we're in the right place. We inject contrast and we make a gigantic dissection that basically will prevent us from continuing. So the technique was what we normally use in coroners. We try to get your wire into a branch. If the wire goes into a branch, you're likely to be in the true lumen as opposed to a dissection plane.
So we see that you switch wires. Which wire do you have now?
I have a Grand Slam. What we're going to do now is laser down the SFA. So we're going to use a 2.0 laser catheter, which goes on a 014 platform.
Hey Jose, it's Raj Malik. You did that very fast, faster than I would have done a fem above knee pop bypass for this patient. But what did you give them any anticoagulation through your pedal sheet? How did you manage that?
I did not. We flushed it, and we're checking the sheath every 5 minutes and flushing it.
Give to Dr. Wiley.
So can I have the panel to discuss, different techniques of ablation? What is your ablation or recanalization device of choice? We're going to see here laser, but definitely there are different atherectomy attitude, or I think everybody has his own. So Sahil, you want to start?
Well, we'll talk a little more about this later in the morning, but I think that there's a whole host of ways of treating this vessel, as opposed to coronary intervention, where once you cross, you place drug-eluting stents and get out of Dodge. Here we have a veritable menu of options, none of which have been compared one against another in a meaningful scientific way. I think for many of us, the practice here would be to dilate this lesion and see what kind of a result you get, and then decide whether you need to use a scaffold of some kind or simply a drug delivery technology. I think atheroablative techniques have some value, and we'll talk about them, but it's not compulsory. And the rationale for doing it here would be to either reduce calcium, which there does not appear to be a lot of, or lipid-rich or thrombotic material. And so in that situation, laser is a reasonable choice. There's a host of other techniques that would be appropriate.
Mitch, what is your device of choice?
For CTOs like this, I would do it exactly as is being done, and would use laser, with the caveat being for a good deal of calcium, or for healthy calcium, I would probably, as you say, do something that's not based strongly in data, and use some type of rotational and or orbital atherectomy to create a channel, just to allow equipment to pass more easily. I think as people have gone on, the days of shoving equipment and balloons and stents down through an occlusion has gotten kind of passé. And I think a lot more people, data notwithstanding, are now using this just to make their lives a lot easier. So that being said, in an occlusion like this, I would feel very comfortable doing laser. Certainly, distal embolization is a concern, but the patient has good runoff, and I think we can feel quite comfortable that's the best move.
So, in coronaries, we're unable yet to prove that any type of atherectomy is better than balloon dilatation. Anybody think here that this study will be done in peripherals and will be able to show it?
You're exactly right. There's about zero data. And so, as you'll see later, giving a talk on the topic is easy. You can just show examples because there's not a lot of data to share. I think it's more that it's an adjunctive technique to an ultimate definitive therapy, and you'll hear a lot about that in the next segment. I think the risk of embolization is well pointed out, but it's probably less than 1% in experienced hands, and this is as good as another technique.
Jose, since you are very experienced with the laser atherectomy, can you show us? And I think not everybody in the audience knows about the setup of the system, and can you walk us through that?
Yeah. So we're going to use a 2.0 laser, which is the turbo powered device, which we will run it on a fluency of 45 meters per millimeter square and a pulse rate of 45. This is a beginning laser atherectomy setting. If we're not able to vaporize the lesion and able to cross, we would then escalate to 65 fluency and a rate of 65 or 70, and we continue to escalate as well. Does anybody would have used rotational atherectomy or directional atherectomy in this case from the panel?
They don't want to argue with you. They are all in
It
agreement.
just depends on how much time you want to spend. I think directional would take longer probably, and I would probably be more inclined to use EPD or embolic protection device. I think rotational aspirational would be reasonable here as well. The so-called jet stream device would be reasonable. I think one other difference compared to our coronary colleagues is that we're much more comfortable doing atherectomy in the subintimal channel here. I think that it's been shown to be reasonably safe when done in experienced hands, and especially with a 2mm laser, you should be pretty safe. The risk of perforation would be probably also about 1% or less, and we have good therapeutic options for treatment of that.
Would anyone consider a drug-coated balloon versus drug-coated stents or interwoven stents? Any ideas?
Yeah, I think just to play devil's advocate, this is Doug, I think my first approach would probably be the inelegant shoving of balloons, as Mitch put it. I'd probably do a balloon angioplasty, see where the chips fell at the end, and then I'd probably use a woven stent close to the origin. It's really hard to stick the landing with the tail end of the stent when you're dealing with a stenosis that comes to the origin, and then I'd figure out what to do with that based on kind of anatomic issues. At the end, I'd probably try to put a different self-expanding stent there, or drug-coated balloons if the post-angioplasty result looked really, really good.
So your approach would be doing balloon angioplasty if there's no flow-limiting dissection, you leave it as it is. If there is, then you would consider an interwoven stent or a drug-coated stent?
As inelegant as it sounds, yes.
Okay.
I think,
Sounds good to me.
as Sahil alluded to, the usefulness of atherectomy is going to be to facilitate more definitive therapy. And so I think in lesions that are maybe more calcified or more diffusely diseased, that as an adjunctive therapy may improve efficacy.
So we hear the laser working.
We're going. So we're lasering at a rate of about 1 millimeter per second, which is what's recommended. This is a robust 2.0 laser catheter. I'm hoping that it's going to cross the entire vessel length. Otherwise, we then have to take it out and use a small caliber balloon.
You're moving very well.
Just a question with the panel while Jose is lasing. What's your sense of having that pedal sheath in there while you're conducting an atheroablative technique? Do you think it's compromising your outflow? It clearly is occluding your dorsalis pedis artery.
Absolutely.
Would you be treating it with vasodilators, aspirating it quickly or frequently rather? What are your thoughts?
Yeah, so what we're doing is...
So actually, I think we're giving a talk on that, but I would, we do give a cocktail when we do get pedal access, and we try to remove the access as soon as possible, as long as it's not needed. So I would probably have taken that access out by this point and just have someone pull manual pressure, and that really should resolve it after 15-20 minutes.
Patient is fully anticoagulated.
Yeah, but I think with the pedal access, most of the pedal access cases that I do, you can take out the sheath and it's right underneath the skin. Even if you're fully anticoagulated, you might just have to hold a little bit longer. But I think the risk of thrombosis is there, especially if you don't have anything in that. You're systemically anticoagulated, but I'm still concerned with the sheath sitting in there.
Sahil,
The technique of removal is analogous to what we do for radial access for coronaries. It's a so-called patent hemostasis, where you have just enough pressure to prevent hemorrhage, but not so much that you're occlusive of the vessel. And with anticoagulation on board, you should actually be more successful at maintaining patency. I think the advantage actually, paradoxically in this case, is that you prevent emboli from going into that end artery and the plantar arch with the access in. Obviously, we'll acknowledge that Jose did it in this case to be sure he had all modalities available for this live presentation.
Remember, with the recanalization, you've improved flow and kind of reduced stasis, and that's better than the situation where it had been before, as long as the patient is fully anticoagulated. remember, there's 3-vessel runoff to the foot. Any emboli are now directed into the PT and the perineal anyway, so it's not like we're abrogating all embolization anyway.
What? Here we had a little difficulty at the proximal cap with the low setting of laser, but right now we have a fluency and a rate of 60 and 80 respectively, and now has been able to cross. We're flushing the sheath with saline. As you know, we don't want to inject contrast unless we're looking for acoustic vibration, which is not what we're looking at this time.
Yeah, it's an interesting point that this is where the cap is located, and you had back propagation of probably just thrombus that's solidified over time back up to the origin there, where you had the last runoff to the profunda. So interesting just to think about the anatomic features of this lesion. One really fundamental question: do you always do your procedures with the patient right side up on the table? Like if you're coming from the left groin for a right leg case, do you ever flip the patient around so the head is at the foot of the table? And I notice you end up with your arms in the fluoroscopy field.
Yeah,
often.
Most of the time, And we have a slave monitor that a lot of times I use, which I should be using now, but yes, most of the times we do it this way. There's few instances that we flip the patient on his belly down when we do a popliteal axis, but most of the times we keep them in the normal standard position.
Doug, what do you do? Because we actually switch the operators to the other side and switch the cameras.
Yeah, we sometimes flip the patient. I mean, it's incredibly annoying because you have, to avoid getting your equipment on the patient's head, it's part and draped in the field. There's very limited area to work on, and it's a nuisance. I mean, this has a lot of advantages, but the ergonometrics of doing it as the operator are also a little bit tricky depending on where the lesion's located. I don't think I would advocate in this particular case based on how far away the lesion is from the wrist, but it'd be really cool to approach this transradially if the equipment were had long enough shaft lengths to get down there, but you would be pretty limited to balloon angioplasty down this far if it's a 6 foot tall man and a little woman. You can often get down with the RX devices down to almost the popliteal and deliver a fair amount of types of techniques and devices all the way down there.
Talking about patient position, and we see Jose here is exposed to a large amount of radiation. And Doug, I know that you care about that, and everybody else, right? We are exposed to a lot of radiation. I'll talk about it later afternoon. And especially in the peripheral position, we see the hands. What do you do? Does it affect how you position the patient? Does it affect how you plan the intervention? How you protect yourself?
Yeah, no, Giora, I think that's a great question. I think, for me, the way that our rooms are set up, I typically would have the patient upside down on the table. I'd be standing then to the patient's left leg side and operating kind of up and over. I think you're also leading to the point that, maybe in one future state when devices are all amenable to the use with robotic techniques, there may be ways to remove the primary operator to a remote locus so they're not directly in the radiation field while operating remotely, which, could be very, very exciting opportunities. Presently, the laser catheter is not compatible, I think, with the use of robotic advancement. But the passage of an 014 wire, possibly even an 018 wire, could be done, with that technology.
I think, unlike the coronaries, in these cases, the vast majority of radiation is supplied by the fluoro rather than cine, and then in DSA, we can step out of the room. So in this case, I see that the fluoro is at least 7.5 frames and a moderate fluoro dose. I think for things like advancing the laser catheter or more mundane things, we can turn down to 3.5 and even have a low dose fluoro because we don't need it. And that will substantially cut down the dose.
Absolutely.
So we just completed the
Sahil?
laser atherectomy. We're going to take a picture.
No, I think radiation safety is extremely important, and all of these techniques, newer technologies, lower dose rates, possibly robotic technologies, and just good first principles of radiation safety are important. We are usually chastising our fellows who have their hands in the beam and try to keep them away as much as possible.
Jose, we are anxious to see how it looks now after the laser atherectomy.
Me too. So we're ready. I'm just going to put a towel over the sheath because we have the wire and it will spray out.
And step back. Protect yourself.
You bet.
So Jose, when you come to treating that osteal lesion, are you going to protect the profunda in any way?
It depends how it looks. I'm going to balloon the entire segment if I think that we have a decent newly created stump. Probably not. If I don't, then I'll absolutely put a wire in the profunda. What would you guys do? You right? Okay. Anybody would protect the profunda?
Probably not.
Oh, we're surely in the right lumen, right?
Open.
Okay, there's not a lot of contour, so we're good.
That's very impressive, Jose.
Pretty good.
Good job.
Thank you. So I'm thinking on doing a balloon dilatation of the occluded segment of the SFA with perhaps a 4050 non-drug-coated balloon, open a channel, and then use a drug-coated balloon throughout the entire segment that was occluded. What do you guys think? Give me a...
Totally agree. And I think something that's incredibly exciting and really inexpensive are just using really long balloons. If you can use like a 22 centimeter long balloon or longer, you can put in just one or two inflations, and I think you wind up with a lot of less disruption at the edges of each sort of tic-tac balloon inflation that we used to get when they were only 3 centimeters or 4 centimeters long.
Just to explain to the audience here that Jose talked about two types of balloon. The first balloon is basically to dilate the arteries. So the way we put the pressure through them is to dilate the artery. And the second type of the balloons is actually in order to get the drug to the vessel wall. They are not intended to dilate the arteries, but basically to elute the drugs that's on the top of the balloons to the vessel wall.
Anyone has a particular preference of drug-coated balloon technology?
Jose, there's no data for any lesion like this long, 30 centimeters or at least 25 centimeters. The data don't exist really in a randomized fashion. If you were to suggest for the audience sake, you'll hear in a little while from Dwayne that there's 3 FDA-approved drug-coated balloons for ephemeral popliteal disease in the United States. The data would suggest that there isn't a class effect, that the balloons perform differently with respect to their patency rates for shorter lesions, but the jury is out for this long segment. I think increasingly as we have price competition and market share wars between the companies, it'll really amount to which drug-coated balloon is on your shelf, more so than any one specific device.
So we're going down with the 4020.
No,
120.
120 rather, Evercross here.
I'm just going to open this channel a little better before we start using our drug-coated balloons.
So, Jose, what's your threshold for stenting?
I would only stent if I had a flow-limiting dissection, and anyone could argue, well, why not stent the entire segment? The patency rate is in the high 80s, but I don't want to deal with possible instant restenosis, which makes it a little harder to treat if that would be the case. I think that leaving no metal behind may be a better alternative, and the data right now with those 3 drug-coated balloon technologies, very impressive. We're talking about 80-some% patency rate in all these devices.
Jose, tell us a little bit about your pre-dilation diameter choice, knowing that you want to keep this balloon underneath, or any pre-dil balloon underneath the diameter of the drug-eluting balloon, but you also want to get a good pre-dilation effect. How do you go about picking that diameter?
Yeah, I usually go 1 to 2 millimeters under the size that I'm going to be treating. So in this case, I'll probably use a 5.0 or 6.0 drug-coated balloon. So I would pre-dilate with 4.0, at most a 5.0. And if I get good expansion, that will be fine. If I don't think I'm getting adequate expansion, then I'll escalate to a non-compliant balloon or a higher diameter.
Are you still pre-dilating for 3 minutes like some of the data suggests, or?
No, I'm going to use drug-coated balloon for about 3 minutes, but the pre-dilation I just want to channel.
So Dr. Malik, you're a vascular surgeon, you know the vessel, you met them in your hands. So one of the things that always bother us in the field that it's clearly the drug-eluting stents are superior to any other technology in the coronary arteries. But that's not probably the case so far in the peripheral arteries. What's the difference in the biology? How do you see why they behave differently? Why they react differently?
Well, I haven't had the opportunity to have any coronary arteries in my hands, but when you do treat these arteries, I mean, there's a lot of calcium, there's a lot of plaque, and I wonder if that just has a role to play in it, whether the drug is not eluted well or doesn't get into the layers that it needs to get into. Even though here the popliteal artery or the proximal or the distal SFA looks okay, but actually when you go in to do a bypass, you'll actually notice that it's very heavily diseased. You'll be fooled. I can say this is going to be an easy pop, but actually I know that artery is going to be horribly diseased, and I think that has a role to play in it.
Okay.
I think that stents in the periphery are just so different than the way that stents in the coronaries can kind of match to the diameter. I mean, you have to think about the distance between the struts, the kinetics of the delivery of the drug from the struts into the areas between the struts, and getting sort of an optimal drug concentration into the wall of the artery. And when you're dealing with such variability in even along the length of a given vessel as to how well expanded it is, how the struts may be kind of compressed in one area or expanded in another, I think it gets to be a really kind of complicated situation to try to resolve with a kind of scaffold-based delivery technology. I mean, they do work, but then again, you're also leaving a permanent implant. Whereas when you do a drug-coated balloon, when you insert that into the vessel, it paints the entire surface homogeneously, and then you're still relegated to the heterogeneous nature of the wall through which this drug then has to deliver and permeate and set up a secondary reservoir inside the wall of that vessel, whether it's calcified or lipid-rich. May have some parameters based on what drug is eluted in there. But I think overall you have much more homogeneous delivery of the therapeutic agent off of a balloon than off of a scaffold.
So do you suggest it's actually a design issue that maybe in the future we will have better stent? What do you think about potential of scaffold, bioresorbable scaffold for the periphery? I know people are starting to talk about that.
Well, now that they're not talking about it for other distributions, there has been data for bioresorbable scaffolds in this segment. It intuitively makes sense, as it did for coronary intervention, but the devil's in the details. I think I'm still bullish that stent-based technologies can be effective, and there will be a second drug-eluting stent. Probably we'll hear data very soon and subsequent FDA approval here in the United States, which is a next-generation device for SFA disease, which will probably be more efficacious than the prior generation. So I think we need to stay tuned. I think scaffolds have some intrinsic value, especially in heavily calcific vessels.
Jose, what are you doing now?
So I'm putting the first drug-coated balloon at the distal SFA where it reconstituted. This is a 6.0 by 120 Stellarex balloon. We're going to have it inflated for 3 minutes. Probably use 2, at most 3 drug-coated balloons. Well, I would like to ask the panel if you have any thoughts of why in the Stellarex trial the non-drug-coated balloon arm showed a patency rate somewhere in the high 60s, 70%, which we have never seen in any other trial using non-drug-coated balloons. Is this a technique? Is this a selection bias? What do you think is the reason why we have such a robust patency rate with non-drug-coated technology.
Jose, they were pretty saintly in how they conducted all their predilation. 4 minutes was their routine time. I think the longer we do, there's some data out there that does suggest the better we do. And if you look at all the DB trials, the PTA arm, the balloon angioplasty arm, did better than in earlier work. So looks like longer is better here.
Yeah, I agree completely with Mitch. I think that we have learned from these trials how to do better angioplasty, which really equates to doing more fastidious predilation and longer inflations. On the other hand, Jose, those patency rates are at 1 year, and they're not really durable, and they start falling off rapidly after 12 months.
I agree. Okay, so we're trying to position this drug-coated balloon right where the SFA reconstituted, so we're looking at the prior films. Go back, Robert. Okay.
Just ask the members of the panel here, how many of you are using either road mapping or a piece of tape on the leg or something like that just to kind of keep track of where you are?
Yeah, I think you really want to cut down the amount of radiation and the amount of runs that you have to do, so absolutely.
Do you use a road map?
I usually do use a road map.
But you can use also, of course, the bone landmarks here. Here it's easy.
Yeah, I mean, with the calcium and everything, I think you can kind of see where you are.
A radio opaque ruler is low tech but very effective.
And for $50, you just put
So Jose, what's the diameter of this balloon?
This is a 60 by 120 Stellar X balloon. I think it matches the nominal size of this vessel. We'll keep it up for 3 minutes. Timer, please.
Timer.
Let's start it, please.
A question for you, Jose, and for the panel. So now we're talking about laser atherectomy. We're talking about at least 2 wires, a catheter, 3 drug-eluting balloons, and then some spot stents for when the dissection is too great. Are you at all thinking about outcomes related to expenditure? How are you starting to insert that into your analysis, or do you just not at all?
Well, I mean, unfortunately, we have to be cognizant about the economics of what we do, particularly because, third-party payers are going to be looking closely at this. I don't think that every lesion has to be treated with atherectomy. There's some subsets that just a balloon inflation and covering with a drug-coated balloon may be enough. In this case, because it's a long fibrotic chronic total occlusion, I think it makes sense to debulk before going in with a balloon or a stent. The issue of using a drug-coated balloon and considering using a drug-coated stent will only be reserved for flow-limiting dissections. Not every dissection requires stenting, so we'll try to limit it as much as possible. We're trying to use the longer balloons we can, the better, so we don't have to use 4 and 5 balloons. We absolutely try to limit the amount of devices in the interest of the economics of what we do.
It's really interesting that, payers and negotiating contracts will argue over $50 for a coronary drug-eluting stent about which is the preferred one, but we'll spend substantially more on an individual case here. But I think the action cannot necessarily be in the cath lab, but in our management of the patient afterwards and trying to utilize same-day discharge and ways to reduce the expenditure after the case is another opportunity, I think, in the periphery.
Hey, Mitch, I have a question for you. After treating a lesion like this with a drug-eluting balloon and you see a dissection that requires stenting, after a drug-eluting balloon, would you then use a bare metal stent, or would you go ahead and put in a drug-eluting stent?
You're asking me, Rob?
Yes.
I would use, given that your lesion's at the adductor canal and it's a calcific lesion and you've already laid down a drug diffusely throughout the lesion, I would use a superior interwoven stent for this. I think you've already got your drug-eluting technology in there, and so I would just put in the best stent that you have for that position. Of course, that's not been studied, and it's intuitive as opposed to database, but it still seems like the right thing to do.
Yeah, especially because the Zilver's a polymer-free drug-eluting stent. The drug is going to bind in a saturable fashion, so you'll have effectively saturated the binding sites with the DCB. There's probably little added value, and you're just going to put a less than ideal bare metal stent in if you put in a DES anyway. That may change with the next generation of drug-eluting stents, but on October 3rd, 2017 in the United States, probably a Supera would be a superior choice.
I agree. Supera is a good stent. We always have to make clear that Supera is a very operator-dependent stent deployment device. If you actually elongate the stent, the patency rate is not as good. If you have the stents too close to each other, patency rate is not as robust as the data we show. It has to be appropriately deployed in order to achieve the patency that the data has shown.
Okay, so you pull out the balloon.
Yeah, we're going to put a second drug-coated balloon. See how far it gets us, and probably have to use one more. Regarding the antiplatelet regimen, routinely we've been using 1 month of Plavix. However, the data is not very robust. Any take-home on this regimen? Should we be using longer antiplatelet therapy? We should leave it at 1 month. What's your take-home?
And if I may extend the Jose's question, whether does it differ when you do just balloon dilatation or drug-coated balloons or stents?
Correct. Anyone on the panel?
Jose, there's no data, again, and so I think that the IFU says at least 60 days for some of the DCBs, some are 90 days. In my clinical practice, I use the APT at least 3 months, or I try to find an excuse to extend it. The worse their runoff, whether they have CLI, those patients I might also use extended DAPT because I think we get better long-term efficacy.
I agree. That's what we're doing.
I also agree. Yeah, I keep them on, as long as possible, if not lifelong.
I would do 90 days here.
Raj, what about surgery? What do you do after surgery? Does it affect patency, long-term patency of the grafts?
You will put them on antiplatelet therapy. It may not necessarily have to be dual antiplatelet therapy. So if it was a vein bypass to the above knee, I'd probably just leave them on aspirin is probably adequate. There's no reason to put them on dual antiplatelet. The debate about putting them on anticoagulation, I think that's not proven. That does not increase patency. So
Really saw the cap yield there right at the end of that inflation, huh?
Yep. It's having a little pain. I think it's stretching the adventitia. But I think that this is the appropriate size. It's another 6.0 by 120 drug-coated balloon.
It's looked nicely dilated.
Are you going to go all the way to the Prox SFA here, Jose?
Yeah, I'm going to try to take it up to the ostium. Yeah, 1/3 balloon.
I mean, I think you're in for a dime. You're in for $1 here.
I'm hoping. Let's see. We shall see. 660.
So Jose, what's your follow-up going to be for this guy? When are you going to bring him back for some non-invasives, or are you going to do any non-invasives or just clinical exam?
I do both. I do a baseline non-invasive test within the first 30 days. I then see them in 6 months and in 1 year. My threshold to do any subsequent interventions is based on symptoms. How many times patients have even an occluded SFA and they develop profound profuse collaterals, and as long as they're not having lifestyle-limiting claudication, I would not re-intervene. So it's all symptom-based re-intervention if I had to.
So will you follow him with ABIs and duplexes, as Ian talked about, maybe, or just ABIs?
I'll probably do an ABI.
What's the routine here on guys on the panel?
I think if you lay metal, you're more likely to use Doppler to help you understand it, because it's not, as we're talking about cost, but it's the cost of restenosis that's potentially even greater. So in-stent restenosis is more complex to treat, and it may be either simpler or advantageous to the patient in the long run to treat. Our surgeons have taught us that something called secondary assisted patency is something that, which basically means you do a touch-up of a prior intervention based on non-invasive imaging, might be a valuable approach in preventing long-term loss of patency.
What does Dr. Del Conde think about the appropriate non-invasive follow-up approach?
Come.
I agree. At least at our institution, we would routinely bring these patients in for a full non-invasive at 3 months, including ABIs and duplex, definitely.
Would you do the duplex also for balloon dilatation without having a stent left in place?
Yes, we would, especially for such a long lesion like this.
So Ian, stand with us. Maybe while the balloon is still eluting, maybe we can have the discussion, and also with the interventionist here on the floor is how do you plan the procedure? So every patient had
How much time?
also a radiological scan, whether a CAT scan or MRI, and ABI. Only one of them, one of them ABI is enough to have the patient on the with symptomatic, of course, have the patient on the table and do the taking the picture and do the intervention, or you take a CAT scan and basically go directly to intervention. How do you play those different types of data?
So I get an ABI and duplex, and if I'm going to treat them, then I'll go straight to angio. If they have no femoral pulse, then I'll get a CT scan to see what kind of aoroiliac disease that may be present if they've had multiple interventions. But in my practice, if I've made a decision to treat, then we'll just go straight to angiography after the non-invasive tests.
Pretty often use axial imaging of some modality or another to have an informed conversation with the patient up front about what we expect to find and treat, talk about durability of the outcome, likelihood of success, therapeutic options.
So in that case, you already have some contrast injected. Do you use the images just to plan directly for intervention, or you take a full diagnostic shot first?
We still have to take a full diagnostic, angiogram just to sort of map it all out and understand where we're going to be addressing lesions. And also, I think it can be confirmatory if you have a lot of, adventitial calcification. It makes it easier to sort of see what the lumen's like and differentiate if it actually is stenotic at certain sites. So I think that's useful. I think increasingly there are co-registration of modalities and the ability to use three-dimensional axial imaging to kind of map your procedure and maybe save on radiation exposure, save on contrast exposure. I think that's a really exciting future state. We're not quite there yet right now at Mass General.
Another interesting point, I think, is where you practice and what the patient population is. So when I was in New York, everybody got a CTA. They came for follow-up. And in Washington, D.C., it's very difficult to get the patients to come back for any additional testing. And so I've had to change my practice from doing some sort of imaging modality to going straight to the intervention at this point.
Show me the first picture. So how would you guys treat if we had laid a drug-coated stents and then we had instant restenosis? What would have been your algorithm if this would have been the case?
I think most of us would do something similar, but usually some sort of atherectomy would be the next treatment and their FDA approval for laser in that case where it works quite effectively, and then perhaps a drug-coated balloon as an adjunctive technology. It's rare that you'll need to re-stent in those situations, and if it's recalcitrant, then it may be something that would require surgical bypass.
When would you guys use covered self-expanding stents such as Viabonds?
I mean, there's data for that, although it's scarce, and I think it's probably better not to put another stent inside of a stent, or a stent sandwich, if you will, in this vessel, than to use drug delivery technologies.
I think a good deal of us try to avoid the low incidence of acute occlusion of the long viabonds, and I think many have moved away.
But it's a really good point that you make, that first failure lowers the bar for proceeding on with the bypass, whereas this strategy that you've pursued here, you may get another 1 or 2 shots on goal before you have to pull the trigger on bypass surgery.
So when would you say is enough less than the patient for a bypass versus a reintervening? 1 reintervention, 2 reinterventions, or what's your protocol?
Why are you being so negative?
Well, we're doing better with the drug-coated technology, but fortunately we still get patients that come back for reintervention even after drug-coated balloon or drug-coated stenting.
Jose, I don't know how you quantify the periprocedural risk of morbidity and mortality of open vascular surgery. I think that's the challenge. As cardiologists, many of us on this panel, we take care of these patients endovascularly because they have concomitant coronary disease, heart failure, and other comorbidities that make them unsavory surgical candidates. And I think that's just the nature of the disease state. So I think that if you can do it with lower morbidity periprocedurally, even if you have more frequent revisits for procedure, there may be advantage. I think that's a value question that is not yet answered.
I think it also depends on what kind of recurrence you have. You know, if your whole thing goes down, then you may want to consider doing something different or lean towards a surgical option at that point. I guess, every patient's different.
Anyone in the panel would have started this case retrograde transpedal as opposed to antegrade as we did in this case?
Personally, I would have done what you did. I would not have done transpedal.
I think it all depended on the first engagement of the ostium of the proximal plaque, and the fact that you met with success there is a testament to your operator skill, but my lesser skills may have forced me had I not been able to engage the plaque and get in there.
I'm sure you would.
But to the point of when to pursue surgery, it's really interesting that the delta between coronary revascularization and bypass surgery for some of these, to use Doug's word, unsavory characters, is much less than the delta in intra-hospital events between vascular surgery and endovascular procedures. So to me, the bar has to be really quite high to take that intraprocedural risk of bypass surgery for the patient, because the event rates among this population are so high, but the event rates for endovascular cardiac complications are so low.
So in this case, as you saw, the SFA reconstituted a little above the adductors canal. If we would have had popliteal disease, would anyone do something different? Would someone done direct atherectomy or rotational atherectomy or another approach?
Depending on the degree of calcification, I think in the POP I would have been inclined to use orbital atherectomy with an embolic protection device. That would have swayed me. I was the charlatan at the beginning who said I would have just put a balloon down and done balloon angioplasty on this lesion, though, to start with. But down there, when I see it more as a no-stent zone, and also especially if there's exophytic calcium, I'd be pretty inclined to use atherectomy.
Now, the data was interwoven stent CV and the popliteal is pretty robust. Would you consider using that type of technology as opposed to bypass in the popliteal?
Well, we're joking on the panel, but I think that one of the other considerations is whether you take away a landing zone for an above-knee femoral popliteal bypass. Just as we worry about full metal jacket of the LAD in a coronary, where you would take away your option for a Lima graft, you have to think about what are the potential downstream consequences and surgical options that may remain. On the other hand, as you say, there are good data for stenting in that area, so it's a game time decision.
Jose, we are running a little late, so we would like to see you inject and see how it looks now after the drug-coated balloons.
This is the real time. Okay.
And then maybe to wrap up, if we can, depend on the result, of course.
So while Jose is about to inject, let's assume that I'm sure the result is going to be beautiful, but let's say the result is less than beautiful and he requires an interwoven stent. So he requires a supera stent, which, as we all know, needs to be matched quite well to the diameter of the vessel lumen. So the question is, he dilated with 6O balloons. What size stent would you now put in? Interwoven stent.
If you're not going to IVUS or use some other kind of quantitative imaging, you'll probably put a 5.5 in, just to be sure. If you IVUS, you'll be exactly right.
And this looks like this looks like a big patient, correct? A big male?
Yeah, relatively. Ready? Okay, we're going to take a picture now. Let's see how it looks. Right. Looks pretty good.
We have good distal flow. What do you think about the proximal part of the lesion?
It's pretty dissected, and the flow is a little sluggish. I think if you took a 30-centimeter balloon, and post-dilated it, you might be able to get a better result. The European colleagues have taught us that if the flow in the SFA is faster than the profunda, you should leave it, let it heal, and walk away, even though that's antithetical to those of us who are coronary operators. But I think you have a chance of getting away without too much stent. And if you're going to stent, you'll probably stent that proximal segment.
Yeah, I would have a hard time walking away from that dissection at the site of the initial occlusion, especially given the way it was crossed, even though it was elegant. But so I would actually make an argument for stenting probably 12 centimeters of that SFA up to the ostium.
Give me a silver PTX.
Doug?
7.0.
Jose, it really depends how fast you want to get down here.
So what we're going to do is, I think that even another balloon inflation may not take it up. I mean, if we leave it up for about 5 minutes, perhaps it may look okay. But I'm leery that this dissection is going to be flow limiting if I leave it alone. I'm going to edge on doing a stent, putting it right at the ostium, and hopefully that would take care of that dissection and prevent flow limitation later on. Anybody has a different opinion?
Which stent?
That's very reasonable. To stick the landing, which stent are you going to use?
I'm going to use a 7.0 by 60 stent, and what I'm going to do, I'm going to flare it distally, and we're going to be injecting from the sheath, and hopefully we'll be able to land it right at the ostium, or at least close to it.
You've got that pedal axis in. Do you want to put a supera in retrograde?
No, I don't think so. I think I'm going to put
I triple dog dare you.
a plain old self-expanding stent. How many minutes we have left?
Minus 10.
Okay, so if you guys want, you could go for a break.
No, we'll see the stand,
Okay,
and then
sounds good.
Then we'll play it by then.
Okay, sounds good.
This would be a great place just to have some, I guess you can sort of see that ischial tuberosity sort of defines where you want to stick the landing with your proximal marker of this, but you got to nail it. And it's hard, I find, to inject contrast around when you're putting a 7mm self-expander through a 6 French sheath. You're just going to be like squirting dye back in your face, through the gasket of this system. You know what? Stuff that we don't really talk about when you're showing live cases, but it sort of happens.
I thought we had a 6 French, but I'm fortunate that
I think getting the right oblique and magnifying up and road mapping it, I think, you really want to nail this and not get into the common.
Correct.
Would any of you gentlemen just pave the entire way with metal at this point, given the spiral nature of that dissection?
I probably would.
I think tacking up the inflow and seeing how the chips fall is not unreasonable, because you can always sort of come through it and then put a supera kind of back up and into where this is. I think that's ultimately what I would have wound up with anyway. If I had stented the origin, I would put a different self-expanding stent, not a Supera, back to the origin because of the finickiness of how you kind of deploy the tail end of the stent and where it lands.
I'd also try to figure out where the reentry was and feel moderately confident that sealing it on the proximal end should be enough, unless there's, really some bulging hematoma into the compromising luminal flow.
So that's the roadmap.
Or a roadmap, or whatever you guys want to call it. So we could appropriately place this stent.
There was discussion about protecting the profunda, but I think when you put a self-expanding stent through a 6, there's just no way to have an extra wire in there. There's too crowded a lumen, so you really kind of can't.
Correct. I think we'll do okay. Let me see the proximal portion of it. Do you see it? Having a heck of a time trying to see the proximal portion of the stent. Do you see it? Robert, pull back the stent.
Right there,
Let's inject hard. Let's see if we see. Let's get a floor fade. I guess the issue here is trying to see where is the proximal portion of the stent. Well, you pull back, you advance.
You see it?
Oh, now I see it. Let's inject, see if we get something. Oh, pull back a little. I think it looks pretty good here, right? Let's take a picture here. Injecting was 1,000 psi. That's why you see some. Okay. You guys see the proximal portion of the stent?
Are you going to protrude across the profunda a little bit?
Probably about a cell or at most. Inject todo that. So I'm going to flare the stent distally, and then I'll pull back as needed. Okay, inject some contrast. What do you guys think?
We all think come back a little
You
bit.
can pull it a little.
Yeah. Inject some dye. Right here. They could always pull. I'm just flaring it. Okay, inject some dye. Let me pull back a little more. We're happy here?
I like it back a little bit.
Yeah, a little more.
Yeah. Try there. A little too much.
That's
here.
too much.
Yeah.
He's committed now. It's okay. It'll be fine.
Yeah,
Let her rip.
it will be fine. This
Gonna shorten just
it's
a
a
tiny
large
bit.
lumen of the side branch.
Just stick the landing.
Well, if we shorten a little, hopefully. We shall see.
It'll be fine. Post dilate. It's the hardest part about live cases.
6040. Okay, we're going to post dilate it, take a picture, and let's see. 6040, please. You probably nailed the ostium, I'm hoping. We'll inject some. That's good for me.
Let's feel.
Little post dilling would be good.
Yeah. My concern was putting the stent across the profunda, which I tried to avoid as much as possible. 7/0 by 40.
7 by 40, yeah. Okay.
Balloon. So we're going to post dilate the stent, and we'll take a final picture, and hopefully we should be done. Would anyone have used a interwoven stent here?
I think we all would have passed on the Supera, as difficult as it was to get that os with a standard self-expanding stent. I think we would have avoided it.
No, balloon. Huh? Balloon. Balloon. Give me the balloon. Balloon. Yeah. Guys, I need a balloon. 7040.
Balloon.
7040 balloon. 7040 balloon. Little miscommunication here, but
you
we should
mentioned
be done soon.
IVUS earlier. Do you do any intravascular images in any of your cases?
Only if I'm taking my ADD meds.
No, I mean, I think what Dwayne is alluding to is that, just like you advance the laser 1 millimeter per second, your IVUS pullbacks, when they're mechanized, are 1 millimeter per second. So for a 30 centimeter occlusion, you're going to be hanging around for about 5 minutes for the whole pullback. But it is very helpful. But I think just as with coronary intervention, once you train your eye, you'll be able to size much more accurately if you have experience. I've got personal interest in OCT, and we do have some experimental data on OCT in vessels of this caliber, and you learn a lot about the pathology with imaging.
Does it change the way you proceed with the cases?
Always.
But I think at this point, he's committed to a 7.0 balloon post-fill.
Of course, yeah. No, I'm going before, like making decisions whether to go with the balloon, go with the stent.
Who would have done intravascular ultrasound prior to delivering the stent in a panel?
Had you been going the route of automatic supera stenting, I think it would have been very useful. I think you could have also made a decent case for sizing your DEB based on the reference vessel size, and perhaps in this large gentleman's case, it would have prompted you to use one step larger in terms of your drug-eluting balloon diameter. But that being said, I think all of the vessel that was diseased did see and was in contact with the drug-eluting balloon, which is probably all that's required.
Do you use it routinely when you do these type of cases, or not?
I think this is one area where sadly cost and hospital economics have really created some challenges. Ideally, I think we definitely would use intravascular imaging in all cases. I think when you're looking at a case like this, where you have this amount of tech, this many drug-eluting balloons, now a self-expanding stent, it's going to become very costly. There are ways to try to make it less hurtful for the hospital, but if you do stack up mounds of these cases, it can become an issue. So I think, given the fact that most very experienced people can be relatively accurate, I think, unfortunately, we do have to avoid it.
I agree. Raj, what would you do in your practice?
I'm sorry, Jose, were you asking me?
Would you do intravascular imaging for a case like this, or you wouldn't?
I mean, I don't think most surgeons do. I mean, we're just, we use a lot of intravascular imaging for aortic work, but I think in the periphery, our training paradigm, doesn't give us that experience.
Anybody in the panel would have used intravascular ultrasound for this case?
No, not necessarily.
No. Okay, let's take a picture.
Question for the panel. Are you using Angiomax or heparin for your cases?
We are talking a lot about costs, so we're using heparin.
I think it's pretty good. Yeah. Okay, let's do a run-up. What do you guys think? There's a little disease right at the ostium, but there's no flow limitation. I think the mouth of the dissection has been already covered.
I really suspect that to cover all that, you're going to be jailing the profunda on the opposite side. I mean, it's just like a high shoulder on one side and kind of low on the other,
Correct.
Looks really good. Flow is so much better. He's going to feel a lot better from this.
So we're going to do a last picture. We're going to do a runoff down to the tibial vessels, and if it looks good, there's no distal embolization, we're done. Robert's going to give some vasodilators, and we should be finishing now. Right? Ready? Inject. We're in business.
That looks awesome.
Yep.
Great runoff. Jose, thank you very much. You really showed us and demonstrated. Demonstrated how to recanalize this chronic total occlusion of this patient and how to make this vessel look good and his leg get a much better supply of blood. And thank you for the panel for the good discussion and covering really multiple aspects of recanalization, opening peripheral artery disease. So we're running a little behind, but we'll take a 10-minute of a coffee break and we will regroup here exactly at 10:45.